Hey everyone, Assalamu alaikum, and welcome to another episode of ECREMtalks, a podcast where we discuss emergency medicine core concepts and the impact of the specialty in the UAE. I'm your host, Anzal Rehman, and today we're going to be discussing some of the major emergency medicine concepts surrounding mesenteric ischemia. Now, amongst the myriad of pathologies responsible for abdominal pain in the emergency department, mesenteric ischemia ranks very close to the bottom of the list in terms of incidence, accounting for barely 0.2% of all surgical admissions. Despite this rarity, however, its significance in the emergency medicine knowledge base cannot be overstated, as the presence of this disease process is responsible for mortality rates for up to 80% when not adequately recognized and managed. Needless to say, a high index of suspicion and careful risk stratification in patients is vital to reducing death in patients with mesenteric ischemia. But how do you recognize which abdominal pain is indicative of mesenteric ischemia and which isn't? Is there a way to reliably screen for this in the ED? How do we manage patients with this potentially lethal pathology? Joining me today to discuss these concepts is Dr. Amani Khalouf. Now, Dr. Amani is a PGY-2 emergency medicine resident at Cleveland Clinic Abu Dhabi. She has got a special interest in cardiovascular emergencies and critical care. And she especially likes to explore and research new innovations in interventional cardiology. Most notably, she was recently rewarded the semi-finalist Young Investigator Award at the Quality of Care and Outcome Research, the QCOR scientific sessions by the AHA in 2021 for a project about cardiovascular imaging in COVID patients. Dr. Amani, thank you for joining us.
Thank you, Anzal, for the introduction. It's a great pleasure for me to be part of the ECREMtalks and contribute to the emergency medicine education in the UAE.
We're happy to have you. Now, before we begin, please make sure to check out our website, ECREM.org. That's ECREM.org, where you can find all ECREM-produced emergency medicine educational content, including free open access med education examination videos, clinical images, and of course our collection of ECREMtalks podcast episodes. You can also follow us and leave feedback and comments for us on a variety of social media platforms, including Twitter, Instagram, YouTube, iTunes, and Spotify, and we'll leave the links for this in the descriptions below. Now, without further ado, let's dive back into our core concept podcast. Acute mesenteric ischemia is described as a sudden or rapid reduction or loss of blood supply to the bowel. Its presence is marked by rapid injury to the affected bowel and should not be confused with chronic mesenteric ischemia, where insufficient blood supply occurs intermittently as a result of postprandial increases in metabolic demand. To better understand the pathophysiology of acute mesenteric ischemia, let's brush up a little on our gut anatomy.
So, the mesenteric blood supply arises from three major vessels: the celiac artery, superior mesenteric artery, and the inferior mesenteric artery. Now, if we remember from our embryology, usually the celiac artery supplies the foregut. That includes the hepatobiliary system, gastric region, spleen, and covers the distal part of the esophagus down to the level of the ampulla, which is the bile duct interus at the proximal duodenum. The superior mesenteric supplies the majority of the midgut, which includes the small intestines, cecum, proximal midcolon up until the splenic flexure, beyond which the inferior mesenteric artery takes over to supply the hindgut, distal to the splenic flexure, which includes the sigmoid down to the rectum. Now, the mesenteric veins parallel the arteries, therefore the superior mesenteric vein drains the small intestines and cecum, while the inferior mesenteric vein drains the descending distal colon and the rectum.
Normally, the small bowel is able to auto-regulate oxygen availability and can even accommodate reductions in blood flow of 75% up to 12 hours. However, in the setting of absolute ischemia, it takes only about 15 minutes for histological changes to begin occurring at the intestinal villi. Left unchecked, transmural necrosis occurs in 6 hours, made worse by leukocyte infiltration, oxygen radical formation, and potential collapse of the mucosal barrier. further contributing to bacterial migration, leading to sepsis, multi-organ failure, and eventually death. It's safe to say this is therefore a time-sensitive process where management early in the disease process will directly impact survival.
Moving on to etiologies, there are four main categories of mesenteric ischemia that can produce this circulatory compromise. Almost half of all cases are a result of arterial embolism. In this case, the heart is the most common origin, and the superior mesenteric artery is the most commonly involved due to its wider diameter and narrow exit angle from the aorta. The most famous risk factor here is atrial fibrillation, but other etiologies such as cardiomyopathy, myocardial infarction, ventricular and atrial dysrhythmias, as well as endocarditis may all increase risk. The second category is mesenteric arterial thrombosis, which is often a consequence of pre-existing atherosclerosis of the splanchnic vasculature, and so may be associated with a history of chronic mesenteric ischemia. Risk factors would include advanced age, diabetes, hypertension, and smoking, as would be expected from a typical atherosclerotic disease process. The third type is non-occlusive mesenteric ischemia, which occurs as a vasospasm in the setting of hypoperfusion or increased sympathetic activity. There is no obstruction per se. Pathology is ascribed to low cardiac output states such as dehydration, sepsis, pancreatitis, and hemorrhage, as well as high sympathetic tones from congestive heart failure and use of vasoactive agents. The least common cause is mesenteric venous thrombosis, commonly associated with a superior mesenteric vein and attributed to prothrombotic states from coagulopathies such as factor-related mutation. Other risk factors include oral contraceptive use, polycythemia vera, and portal hypertension.
So now that we have an idea about its pathophysiology, let's talk a little bit about how this manifests in the individual and how a patient with mesenteric ischemia will present. We've already touched on how rare this condition is, and the differential for abdominal pain in the ED is already incredibly vast. So, are we looking at a needle in a haystack, or can we more feasibly arrive at this diagnosis? It's important to note that symptoms of mesenteric ischemia will depend on the underlying causative factor. Ischemia from embolism tends to present suddenly, while venous thrombosis may develop over several days. The classic triad of acute mesenteric ischemia includes abdominal pain, typically out of proportion to physical exam findings, gastric emptying in the form of either vomiting or diarrhea, sometimes with blood and stool. And finally, the preceding signs occurring in the presence of what is usually a prothrombotic state or cardiac disease, such as atrial fibrillation or myocardial infarction. Now, unfortunately, as luck would have it, and with so many of these kind of etiologies, only around 1/3 of patients will present with this typical triad. But there is one aspect in this triad that's worth exploring a little further. The nature of abdominal pain in mesenteric ischemia is unique in that it is out of proportion to examination. We've all heard this and we've all read this and we've all gone through this whenever we've been pimped on grand rounds. It's often refractory to significant analgesic intervention, this out of proportion pain. So things like opioids seem to be in play or probably not as effective as they should be. That is to say, the patient will be writhing around from the visceral pain. However, due to the absence of peritonitis, or the usual absence of peritonitis, so to speak, there will be no evident tenderness or guarding on palpation of the abdomen. And this is where the term pain out of proportion comes from. And I like to sometimes refer to this, and it has been referred to as poop, if you haven't heard it before. And this isn't the first time you've heard of poop. Compartment syndrome, necrotizing fasciitis, aortic dissection are just some examples of where poop, quote unquote, manifests. Hence, it is commonly attributed to as a harbinger of considerably serious underlying disease. So having this as one of our findings isn't unreasonable to suggest something sinister. It isn't something to be ignored, for sure. While the incidence of nausea, vomiting, diarrhea, and rectal bleed can range from 15 to 45%, abdominal pain in of itself is present in around 95% of patients with mesenteric ischemia. So, to bring this all together, diagnosis of mesenteric ischemia relies on a high index of suspicion in a patient with abdominal pain that may be out of proportion and may be associated with postprandial worsening, who also have risk factors such as age more than 50 years old, presence of atrial fibrillation or other coagulopathy or cardiac disease, and or a low flow state such as sepsis or congestive heart failure.
Now, once we've established suspicion of mesenteric ischemia, it's time to move on to other indicators or investigations that could be useful to clinch that diagnosis. Unfortunately, despite a myriad of proposed lab markers and diagnostic modalities, very few have shown to be reliable or specific to identify mesenteric ischemia. A systematic review in 2013 by Acute et al., if I'm pronouncing this right, looked at various serum markers such as lactate, D-dimers, fatty acid binding proteins, and alpha-glutathione S-transferase, but found no reliable evidence supporting the use of any of these in diagnosing mesenteric ischemia. D-dimers had the highest sensitivity but low specificity, so there may be some room to explore this as a rule-out test or a screening test. Lactate is moderately sensitive but also nonspecific. However, given its rapid turnaround time, it may have a role in serial monitoring. Other findings that may be present include leukocytosis, elevated hematocrit, elevated amylase, troponin, or metabolic acidosis. Based on guidelines issued by the World Society of Emergency Medicine in 2017, no laboratory studies are sufficiently accurate to identify the presence or absence of ischemia necrotic bowel. But lactate and D-dimer may be of some assistance. X-rays are not very useful until perforation is established. By and large, the most accurate and consistently useful tool at our disposal is the CT angiogram for suspected arterial embolism or thrombosis. This has replaced angiography as the best initial test of choice since it is more readily available and easier to perform for suspicion of mesenteric ischemia, with impressive sensitivity and specificity of 94 and 96% respectively.
So, let's say we finally have a diagnosis of mesenteric ischemia. What's next? Working through the pathophysiology we discussed, we know that therapy should involve restoring that blood flow as soon as possible, preventing further clot formation and vasospasm, and treating the underlying condition propagating the decompensation. Management should focus initially on fluid resuscitation and hemodynamic stabilization. Keep in mind, these patients may have significant third space losses and may even have bleeding secondary to bowel wall injury and necrosis. For this reason, make sure to include blood products in addition to crystalloids where bleeding is suspected. As early as possible, initiate broad spectrum IV antibiotics to cover for potential bacterial infiltration of ischemic or necrotic segments of bowel. Correct electrolyte imbalances as needed, keeping a particular eye out for acidosis and hyperkalemia. Where vasopressors are required, use dobutamine or milrinone, as they are likely to have a lesser impact on the peripheral vasculature, and they are then less likely to exacerbate the mesenteric vasculature and cause further vasoconstriction. Establish nasogastric decompressive measures and use opioids as needed to control the severe abdominal pain. Call your surgeon early. Depending on the extent of injury, patients may require endovascular therapy, angiography with embolization, emergent laparotomy, and even bowel resection. Some debate exists surrounding the use of papaverine infusions through the angiographic catheter, particularly for non-occlusive mesenteric ischemia. Several reports also advocate systemic anticoagulation with heparin, with perhaps more benefit in mesenteric venous thrombosis. Now, while these therapies may be of benefit, we recommend initiation of papaverine infusions or anticoagulation in conjunction with surgical consults and after surgical review, or alongside those, based on a care plan individualized to your specific patient and case. These patients ultimately are often admitted into intensive care settings and require a multidisciplinary approach to effective management. As we wrap up our episode on mesenteric ischemia, Dr. Amani will cover this session's core concept summary.
Okay, so down to core concepts. Acute mesenteric ischemia is a vascular emergency defined as reduction or loss of blood supply to the small intestines. The most commonly implicated vessel is the superior mesenteric artery, with the most common mechanism being occlusion from an arterial embolism. Other pathologies producing mesenteric ischemia include mesenteric arterial thrombosis, non-occlusive mesenteric ischemia, and mesenteric venous thrombosis. The classic presenting triad of abdominal pain out of proportion to the exam, gastric emptying, and cardiac disease is often not encountered in patients. Diagnosis require a high index of suspicion for abdominal pain presenting in older patients with appropriate risk factors such as AFib or prothrombotic states. CT angiogram is the test of choice to confirm the presence of disease. Serum markers are not recommended to reliably include or exclude the presence of mesenteric ischemia. Management involves aggressive fluid resuscitation with IV broad-spectrum antibiotics as needed, prioritize effective pain control, and early surgical consultation and transition to definitive management. Remember, early recognition and intervention is the key to preventing potentially devastating morbidities and mortalities from this disease.
That concludes our episode on mesenteric ischemia and our brief overview of its core concepts. I have to say it was an absolute pleasure going through this topic with you, Dr. Amani. We're very happy to have you on board with us at ECREMtalks.
Thank you, Dr. Anzal. It's been an equal pleasure for me as well, and I believe that we've covered a very important topic in emergency medicine that, as we stated earlier, we don't encounter as often and therefore not on the top priority of differentials more often. However, it's equally important in terms of morbidity and mortality, and it's very important to recognize. Thank you.
Couldn't agree with you more. Thank you so much again for joining us on ECREMtalks. We hope to catch you for our next episode very soon. Don't forget to check out all our ECREM content on ECREM.org. Again, that's ECREM.org. And visit our social media accounts through the links in the description below. Until next time, this is ECREMtalks signing off.